I'm Gert Matthijs. I work in Leuven in Belgium, and I'm involved in genetic diagnostics, but also in rare disease research. And I'm particularly interested in the ethical and societal aspect. So I think this is part of today's sessions. I don't need to introduce rare diseases, but what I do like is what the patient association use as slogans, and they say, "Alone we are rare, together we are strong." So I want to start by acknowledging that most of the efforts actually are done by the millions of patients and parents and families that have to deal with rare diseases on a daily basis. So thank you to all. As an introduction, I think we have a global unequal distribution of rare disease support. One is first an unequal distribution about incidence, for sure, among populations, but I think we also should take into account not just the differences in ethnicities, but also in the age distributions. I think that's a particular issue. And then the second thing is that the provisions of the clinical and diagnostic services are very variable. And there I personally want to insist that this is not just an issue for geneticists, but this is an issue for all medical specialists and all caretakers. And then, as we will learn today, awareness is a problem and social acceptance is a problem as well. So then it's therefore my pleasure to introduce the first speaker. That's Dr. Michelle Thunders. She's at the Department of Pathology in the University of Otago in Wellington, New Zealand. So welcome from the other part of the world, or the other side as far as I'm concerned. Dr. Thunders has a strong interest in genetics education, not just for medical practitioners, but actually for all. And on her research side, she's pushing knowledge into the epigenetics and the epigenomics of environmental influences and exposure. So this is a quite varied interest. So Dr. Thunders, the floor is yours.
Thank you. So good morning. Thank you for allowing me to present at this conference. I hope you're all staying well in these very difficult times. I very much look forward to a time when we can meet again in person. I'm going to talk briefly today about genomic medicine education in New Zealand and what some barriers and solutions have been for us and what we're currently doing. So you can see we're a very small country and we're geographically isolated. We're situated in the Pacific Ocean. Our population is under 5 million. And so obviously there are restrictions with funding associated with this. Our health system is mainly funded through general taxation, and this is about $16 billion, but that's for the whole of our health and disability system. So genomics is not a massive priority in our country. We have 2 medical schools, so this again gives you an idea of the scale of our country. We have a medical school in Auckland, and we have a medical school in Otago, so there's 2 medical schools. And the medical degree is relatively the same as elsewhere. There is a 5-year program, and after the TI year, after the students will do 2 years house officer training. In terms of our population, New Zealand comprises of different ethnicities, majority being European Caucasian, but our population is made up of European, Maori, Pacific, and Asian, and this is getting increasingly diverse over time. About 14% of our population identify as Maori, which is our indigenous population of New Zealand. And the Maori culture is integral to New Zealand way of life. However, in New Zealand, ethnic identity is an important dimension of health inequity, and Maori health status is demonstratively poorer than other New Zealanders. And so there's lots of actions in New Zealand to try to improve Maori health. And it's very important for us as New Zealanders to put this central to our healthcare initiatives. So our initiatives are trying to be designed to improve the health of Maori people, including the establishment of Maori healthcare providers, cultural competence training, community-led programs, and a health literacy focus. More recently, the Whānau Ora initiative was launched, and this is cross-government and culturally grounded approach to providing health services and opportunities to families. Could I have the next slide, please? Just give a little bit of background about who are the genetic professionals in New Zealand. And again, numbers are small. So currently in New Zealand, we have our genetic health service is delivered by genetic professionals who comprise genetic counsellors and clinical geneticists. So in our country, we have about 13 clinical geneticists and 18 genetic counselors. And genetics is delivered in terms of delivering genetic support and advice through 3 main hubs. We have a northern hub, a central hub, and a South Island hub. So these are the clinical specialists, genetic specialists, who deliver the majority of direct patient contact. So obviously these numbers are small, so for us it's important to try to open up genomics to healthcare professionals and also our wider population, so that more people are sufficiently knowledgeable and any developments are equally beneficial and available to all of our population. And so part of our genomics education that's really important is to ensure these developments are going to be perceived as beneficial to all of our population, and that genomics can be used as a tool for treatment and diagnosis. And so we need to not only enable our population, but also enable clinicians who are not genetic specialists to see the benefits, power, and relevance of genomic medicine to their practice from the perspective of patient care. There are, in terms of our undergraduate medical training, we have the medical curriculum is divided into early learning medicine and advanced learning medicine. And one of the initiatives that I'm working on at the moment is based that we're delivering from the pathology department. We are developing and delivering a series of genomic medicine sessions for our fifth-year medical students to try to get them more used to the increase in genomics information that's going to be part of their practice when they become qualified. So we're delivering the genomic medicine component, but we're also targeting postgraduate qualifications. So we've developed a postgraduate paper, and this is going to become part of a certificate that's targeting general practitioners and pharmacists. And this is genomic health and medicine. And so the aim of this paper is really to give other health professionals an opportunity to upskill and become more aware about genomics and the relevance of genomics to their practice, and also has relevance to pharmacists, nurse practitioners, and other non-genetics specialists. And we've delivered a paper so far, and the cohort we had a mixture of GPs, pharmacists, as well as other non-medically trained healthcare practitioners. In terms of genomics in New Zealand, currently, aside from genetic testing, primary use of genomic testing is in oncology, with pathologists playing a major role in cancer diagnosis. This is starting to change, and recently pharmacogenomics has become more widely discussed and introduced. And there is a company called Ventures, which has formed a partnership with an Australian-based genomics company to make pharmacogenomics more available in New Zealand. And there's also been an important consultation process where Ventures have collaborated with iwi and Maori health providers in this work to ensure that it's culturally appropriate and that the correct procedures are in place alongside this initiative. And also there is a work to make sure that this is going to be subsidised so that there are some panels available. In terms of funding, there was some government funding to the tune of just under 40 million New Zealand dollars. And this is a partnership, a precision-driven healthcare partnership, and a collaboration between universities, the government, and private companies, and where the focus is really to improve research on the importance of data to precision healthcare, and also an important aspect of this is patient empowerment. Another key arm of this project is New Zealand's first genomic database, and again, this has been a collaboration with iwi to make sure that it's fair for all of our population. And so the program is taking aim at major health inequities that still leave Maori and Pacific people worse off in our country. And so for us, it's really important that we need to understand our unique population. It's really important we need to get buy-in from our population, and also we want this to be beneficial. And so that we're not just studying genomic data from overseas, we're studying our own people. And so part of this initiative is also including sequencing the genomes of 500 local people. And so we're hoping that this will put the needs and priorities of the Maori people as well at its centre. Can I have the next slide, please? And so this is just giving you a little bit more data about the postgraduate certificate in genomic health and medicine. And a key aspect of this is that we've made it very flexible and organic and student-led. So some of the students don't have a huge amount of experience in genomics, or they are GPs that graduated from med school 20 years ago. So they may be a bit rusty. So we've had a very comprehensive and short induction to what genomics is. And then we've let the rest of the course be very much student-led by their interests, by their practice, and going through a variety of different scenarios, from single gene defects through to complex scenarios, through to lifestyle, direct-to-consumer testing, and epigenomics. And so what we've done is try to make it so that the students can produce a project at the end of the paper that's practical and relevant, and they'll be able to take something away and back to practice, ideally, so they can then become proponents and leaders for genomics in their field. And have the next slide, please. And then this is just giving an idea of what we're doing for our fifth year med students. So this is for us the genomic medicine component. And what's been important here is that we're working with the University of Auckland to have a consolidated combined objectives of what we think is important in a genomic medicine curriculum for medical students. And this here is just an example of one of our online learning modules that we use, and we're trying to make it very clinically focused, case-based scenarios, not a whole load of biochemistry or genetics 101, but very much what the clinicians need in practice right now, or when what they're going to encounter. And so we try to make it very useful, but also giving students a toolbox of resources so they know where to look and how to find information, rather than having to learn lots of individual specifics about lots of different diseases. So for us, it's been key to make it competency-based and skills-focused. And have the next slide, please. And so I just want to finish on this, which is, for me, has really been some of the barriers and solutions. So I'm not a native to New Zealand. I did my training in England. So coming to New Zealand, there's been some stark differences from coming to a country that has a smaller population and limited funding. So for us in New Zealand, barriers are obviously the inequities in health in different populations and funding, the geography of being pretty much away from everybody else in the world and having a small population, and really trying to come around to people's perceptions and beliefs that genomics can be beneficial. And key for us for success has been inclusivity and consultation, and this is really important in dealing with Indigenous population, that it has to be led in collaboration, and it's not something that can be forced upon the population. So for us, inclusivity, consultation, collaboration has been key. And just a realism that we are a small country, and so there's an element of self-sufficiency in terms of what we can do and when we need to ask for help. And for us, online learning has always been a big proponent, so adapting to lockdown has not been too bad for us because we're used to being geographically isolated. I'm happy to share any information we have on our curriculum that we've talked about, and any ideas that we have about teaching, if that's helpful. Thank you.
Thank you, Dr. Tundras. This is indeed fairly well organized for a small country, because it's not only about finances, it's about the number of people who can do the job. I have two short questions from the audience. One is, how did you manage to create, and how will you maintain what you call the Genomics Database New Zealand? So what's the endeavor?
Well, that's in very much the early stages at the moment. So it's only just recently received funding. So at the moment, I'm not sure what the long-term plans are, but the initial, I think it's just received 5 million government funding as an injection to get that started. I think the idea is that the data will be very much used, and the ownership will be held by the population contributing their data, and it will be linked with medical records for research, specifically for the New Zealand population that participates.
And then the brief second question is whether you have, what I understand from the question, remote or distant telephone and other programs for clinicians in practice. So how do you reach people other than in regular education?
Yes, I mean, it's difficult. So we don't actually have a genetic counselor program. So if people want to be genetic counselors, they typically get trained in Australia, or do their training in Australia. We do a lot of online learning. So typically for the teaching healthcare professionals, we have Zoom meetings in the evening. We'll do video recordings. We do bite-sized lectures and deliver it. We often have a lot of students who are out in rural placements, and they will also rely heavily on our online learning via different types of, we use Moodle, which is kind of like Blackboard, and we use different types of online modules to try to make the learning more interactive.
Okay.
Or sometimes we have to just use phones if we can't access.
Thank you again for this
Thank you.
presentation. Then it's my pleasure to introduce the next speaker. That's Dr. Jürgen Reichert. Admittedly, this is one of the people that have been present in the early days of gene discovery more than 30 years ago, if you allow me to put a figure on that. But you've been active in gene discovery and in cancer prevention as well. Dr. Reichert is currently at the Australian Institute of Tropical Health and Medicine. And for the sake of today's session, it's important to know that he is a member of the Council of the Human Genome Organization, as well as the Human Variome Project. And today, you do represent the Diagnostic Scientific Committee of IRDIRC. So I'm looking forward to first have an introduction, I guess, on IRDIRC, and then have your opinion on these rare disease programs.
Thank you, Garrett. If I could have the first slide, please. So if Garrett mentions, my task today is to introduce the International Rare Diseases Research Consortium. So that's number one. Second thing is that we'll talk a little bit about the Diagnostic Scientific Committee, which is number two, which is how I got into or invited to speak at the G2MC. And three, I will throw out a few provocative ideas to sort of get the discussion going. Before doing that, we're all in interesting times, so I hope you're all doing well and having fun occasionally. So let's also have some fun. If I could have the next slide, please. The International Rare Diseases Research Consortium, or IRDIC for short, is an international grouping of people which really spans a variety of continents and is basically focused on rare diseases to coordinate and maximize the outputs. It includes researchers, clinicians, but also pharma. So it is an interesting grouping. And the vision is to enable people that have rare diseases to receive accurate diagnostics. But of course, a diagnosis doesn't mean anything if there isn't a cure or at least care available. And one of the goals of IRDIC is to have that available for patients within 1 year of coming to medical attention. If I could have the next slide, please. So the three goals by IRDIC, and it's funded by pharma industry, there's some grants in Europe, is to have all patients that come to medical attention with a suspected rare disease diagnosed within a year, if it's known in the medical literature. And interestingly, I think for people who are interested in genomics, we want to have undiagnosable patients who will enter a globally coordinated diagnostic and research pipeline. I might say a few things about how genomics, metabolomics, and all that kind of stuff plays in there. Now, goal two is to develop 1,000 new therapies. And so remember that pharma industry is involved in this. And so they, of course, have an interest in therapies. But of course, the patients do as well. And I forgot to mention that we do have patient advocates also that sit in IRDIC and they make valuable contributions. So the goal by 2027 is to have 1,000 new therapies for rare diseases. And lastly, or thirdly, is methodologies will be developed to assess the impact of diagnoses and therapies on rare disease patients. If I could have the next slide, please. So how does IRDIC work? It really works mostly through task forces, and I'll have a few things to say about specific task forces on the next slide or the one thereafter, but the overarching themes are to address specific R&D research needs or bottlenecks for rare disease. The projects are identified and developed by IRDIC committees, and so the Diagnostic Scientific Committee is one of these committees. Projects can sometimes be developed in collaboration with other organizations, and maybe the G2MC would be interested in joining us, or if any of your institutions or yourself want to join us, I'm sure there is a way to do that. We involve IRDIC members, but of course also external experts, and we provide solutions through policy recommendations and technical applications. Next slide, please. So I mentioned that task forces and working groups are really the main way that ERDIC works. And they usually run for 3 years. So anything that goes back to 2017 or earlier is basically concluded. We'll have to see how COVID is going to impact that, and I'll have to say something about that in a minute. But so both Andrew and Michelle mentioned indigenous populations, and so one of the things that the Diagnostic Scientific Committee is interested in is in fact indigenous populations. That working group or that task force was launched last year. We met virtually in March of this year and are starting to get things going on that. The other thing that's on the drawing board for ERDIC is to form another task force or working group on modern technologies. And so I am personally, for example, particularly interested, of course, in genomics, but also metabolomics and other omic technologies. I will confess that one of my personal biases, based perhaps in part also in my interest, is that we probably have unknown metabolic pathways that are still kicking around somewhere. And so some of them may well lead to rare diseases, but of course also to new scientific discoveries and new therapies. So I think combining metabolomics, genomics, and other omics in patients with rare diseases that have undiagnosed diseases may well lead to new diagnoses and therapies for these patients, but also to novel insights into basic biochemistry and basic human biology. If I could have the next slide, please. So I sit on the Diagnostic Scientific Committee, and this is how we originally got involved because the DSC was asked to contribute something. And so the DSC, the Diagnostic Scientific Committee, is committed to one of the goals, especially of 2027, namely that all patients with rare diseases that come to medical attention will be diagnosed within 1 year if the disorder is known in the literature. Or currently undiagnosable individuals will enter the globally coordinated diagnostic and research pipeline. And I think that's where this genomics and metabolomics working group may well come in, and that remains to be developed. Maybe G2MC or some of you might want to take an interest in that. And then, of course, we want to identify current and future bottlenecks to rare disease gene discovery and address the challenges and roadblocks in rare disease diagnosis. And we will collaborate with international partners, for example, G2MC or other people such as yourself that are sitting and watching this. And we will provide tools and resources to facilitate genomic data discovery, analyses, and data sharing. Next slide, please. So the current composition of the DSC is listed here. It's relatively broad. I've noticed that there are several people who appear to have Spanish last names, and I'm sure those people will immediately be drawn to the map of Latin America, and Ecuador is still in red there because before I returned to Australia, I actually spent some time in Ecuador. So one of the things that especially the indigenous task force will be interested in are people from Latin America who may want to contribute work on indigenous populations. If there's anyone of you out there, please get in touch with me and I'll try to coordinate that with the indigenous working group. Next slide, please. So these are the ongoing task forces of the DSC, the Diagnostic Scientific Committee of ERDIC. And so I mentioned repeatedly now the Research and Diagnostics Research and Development Diagnostics Committee for Indigenous Populations and Underrepresented Populations. It's chaired by Gareth Dunham, who is at the University of Western Australia. He has several Indigenous individuals working with himself. I think Andrew already did a terrific introduction to Indigenous populations, especially in Australia. Currently, there are maybe 300 to 500 languages that are still alive, but the guesstimate is that there used to be 5,000. So there is a great deal of diversity in the indigenous population in Australia. But I also mentioned that I do think we want to include Latin America. So if any of you have an interest, please come and contact me. We have people from New Zealand working with us, people from North America, and we have some people from Africa. We held a more or less successful workshop in March of this year in Berlin. So this was the beginning of COVID. And so my trip started to fall apart as I was getting onto planes. So it was an interesting experience. At the time, countries were closing their borders while I was trying to get there. So it was interesting. Hopefully this task force on indigenous populations will have some results, and we still have at least 2 years to go on that. So if you have an interest, please let me know. I'm happy to facilitate that, especially if you're in Latin America. And I think I have one more slide, is that correct? So I thought I would be a little bit provocative and throw out a few ideas. And as one, of course, does, we're going to start in the lower right-hand corner. So earlier this year, we published a paper on rare diseases in Africa in Nature Genetics. And this was done mostly by the DSC, the Diagnostic Scientific Committee of ERDIC. I would be happy if we could get something started here at G2MC that would work on rare diseases in Latin America. I see that there are a number of people who appear to have Spanish last names or Spanish names. So if you have any interest, please contact me. I'm happy to facilitate that if we could put something together along the lines of what we did for Africa and Nature Genetics. I'm not sure that we would have that many co-authors, but that I think depends on who wants to participate. The other thing I want to mention briefly, I've sort of become a little bit of a politician as things have moved along. We will try and put a report together on virtual genetics and genomics meetings. The part on the human genome meeting, which was a month ago, is basically written up. We hope to have something with the aid of Gabriela Repetto, who I see is sort of on this call, on G2MC. If you have any ideas on what should go into that manuscript, please also contact me. And last but not least, and I think important for Latin America, and that's the two top papers, one in Science and the other one in Nature. If there is some interest in putting something together on research universities in Latin America, I will be delighted to also facilitate that. Yachay is the Quechua word, one of the indigenous languages of the Andean indigenous populations for knowledge. And so I spent some time, 3 years at Yachay, which was meant to be a research-intensive university in Ecuador. And so if there are people who want to write something more political on research universities in Latin America, I'm happy to also facilitate and participate in that. With that, I thank you for your attention.
Thank you for this contribution and this quick introduction to IRDIRC. It's again one of these examples where many people are extensively contributing to what I call community activities. So it's all volunteers like yourself who are doing this work. The questions that pop up are the ones that you actually launched yourself mostly. So I want to take them or keep them for the panel discussion. I think Bruce will be happy to take all the questions that have been raised right now. So that's why then I'm happy to go to the next speaker. The next speaker is Dr. Maria Cecilia Poli. She's an immunologist and a rheumatologist at the Clínica Alemana in the Universidad del Desarrollo. I'm not so good in Spanish, but I can just add that you're in Chile, and because we're all virtually in Chile, we'll be happy to listen to your talk. Your research, as I understand, is in immune deficiencies, but your commitment is to much broader activities into rare diseases in your country. So please, Maria Cecilia, go ahead.
Thank you very much for that nice introduction and for inviting me to speak here. Next slide, please. So Latin America has several barriers to diagnosis in rare diseases. One is that we, for the most part, don't have universal newborn screening for many of the rare diseases. Genetic testing is also not covered in most of Latin America, so this becomes a second barrier to diagnoses. And then registries, which have shown to be important in this regard, are also include some individual rare diseases, but they don't take rare diseases as a whole for a registry. So there's a pressing need to view rare diseases as a larger entity to impact public policies for diagnosis and treatment and to move forward in this regard. Next slide, please. So diagnostic and treatment programs, as I said, are focused on single rare diseases, and there's a need to view this as a larger entity, sort of putting everything under the same umbrella to help assess real needs in terms of testing, coverage, and orphan drug necessities, which we lack access to. Next slide, please. In Chile, we estimate that we have more than 1 million people affected by rare diseases. We do have diagnostic and governmental programs that cover some aspects of 20 or so rare diseases, but there's a lack of comprehensive coverage for both diagnoses and treatment. We do have a program for chronic diseases in children, but this doesn't cover diagnoses and it doesn't cover specific treatments. So there's a lack of integrated diagnosis and treatment programs, and rare disease patients are still facing this diagnostic odyssey. Next slide, please. So we came up with this interdisciplinary research approach to undiagnosed diseases, and I would like to tell you over the next few minutes some of what we've done over the last 2 years with our project that we call Deciphered. Next slide, please. So Deciphered stands for Decoding Complex Inherited Phenotypes of Rare Disorders. And our main goal is to provide interdisciplinary approach to patients with rare and unknown diseases with multidisciplinary clinical assessment, unbiased genomic sequencing, comprehensive bioinformatic, and interdisciplinary variant interpretation, which we found to be very important, mechanistic discovery, and also hopefully therapeutic target identification in the future, and importantly, promote public policies and regulatory aspects for rare diseases in Chile. Next slide, please. So we've enrolled patients with congenital anomalies with or without neurologic manifestations, undiagnosed primary immune deficiencies, and other rare diseases as a suspected Mendelian inheritance with no genetic underlying explanation after routine testing, which is basically panels, CMA, and MLPA, and things that we have available in Chile. We perform a group analysis of all the previous testing that has been done and the clinical manifestations using HPO terms. Patients are sequenced and annotated, the bioinformatics is done, and then we perform a group analysis where we do use multiple tools available online. But next slide, please. We found particularly valuable to work in group, and you can see here part of our group of scientists, clinicians, and bioinformaticians all working together and sort of looking at these variants together. So over the last year, we've enrolled around 60 families, which we've evaluated in collaboration with other centers like Baylor College of Medicine. We've incorporated other national collaborating centers to be able to enroll more patients around the country. We've added 4 new scientists. We've incorporated trainees into different aspects of the work, sort of trying to grow our group and be able to get to more patients. Next slide, please. We've faced some challenges, and one is that we were first asking ourselves, was it worth to run clinical exome, which is not available or covered for in our country, versus whole exome sequencing with the patients we were enrolling? And we quickly looked at the first 5 patients in which we did both, and only in 2 out of 5 of them we were able to get a diagnosis with a clinical exome, while we had missed 3 that we did diagnose by Wes. So we decided that for patients with no suspected diagnosis or clear syndrome, we would do whole exome sequencing. We also asked ourselves if we would do an in-house annotation versus using commercial softwares. We've tried both, and we have seen that both perform well for research purposes, although if we would like to use this as a clinical testing, we would have to use the commercial ones that are approved for that. We've also looked into looking at family trios versus proben testing, although family trios have a little bit more higher yield. For our limited resources, we've decided to use proben testing as an initial approach and save parental DNA for future testing. Next slide, please. So these are results for the congenital anomalies and intellectual disability cohort. We've had a diagnostic rate of 40% with 2 gene candidates that have to be confirmed. Next slide, please. And for the immunodeficiency part of the cohort, which comprehends 34 patients up to now with multiple different primary immune deficiency syndromes. Next slide, please. We had about a fourth of diagnostic rate with 2 patients having multiple molecular diagnoses. But if we look at this 77% where we had in an initial round no molecular diagnostic finding, after reanalysis, which became very, very important, we found 2 patients that had strong candidate genes which are now almost functionally confirmed, and another 7 that have likely candidate genes that need functional confirmation. So even in the small cohort, we were able to identify novel candidate genes for primary immune deficiency. Next slide, please. So this is one of our interesting patients that we identified in this cohort. This patient had skin lesions and recurrent infections, and she had very specific different skin lesions. Ones were chronic granulomatous necrotizing inflammatory process affecting her cartilage in the nose, and inflammatory infiltrates in her extremities that were consistent with neutrophilic dermatoses. Next slide, please. And we did find 2 different primary immune deficiency mutations, which were novel. Thus, they had to be functionally confirmed, which we did. One was for CANDLE, and the patient had an elevated interferon signature. And the other one was for MHC class 1 deficiency, which we confirmed by flow cytometry. So this patient had a multiple molecular diagnosis. Next slide, please. The next slide, please. And this is another patient in which we identified homozygous variant in FNIP gene. She had no circulating B cells and resembled a mouse model with FNIP knockout. And this is also another novel gene discovery that we hope soon to be published. Next slide, please. So in conclusion, comprehensive programs for diagnosis and treatment of rare diseases as a whole are greatly needed in Chile and in Latin America. Whole exome sequencing and team-based analysis is a powerful tool for diagnosis and discovery. Even in small countries with small cohorts like ours, collaboration is crucial. And there's multiple tools to do this nowadays online. Functional studies are key to demonstrate pathogenicity of novel variants and genes. And so moving forward, the implementation of a functional diagnostic pipeline is needed in our country and also in Latin America. And I would like to just leave you with this phrase by Charles Darwin of how important it is to collaborate and sort of improvise as we've done with our cohorts. Thank you.
Thank you very much. This is indeed an example of collaboration nationwide, if I understand well, and especially with limited budgets. I don't even want to ask how your budget compares to the Australian.
Oh, yeah.
Was presented earlier. And again, it's about how individual countries can organize. So this is something we shall deal with, or at least will be brought up in the panel discussion. So thank you for the presentation. And then I quickly move to the next one because we're all keen to have that panel discussion later on. So the next presenter is Kelly East. She is a genetic counselor working at the Hudson Alpha Institute. She has, if I may say, more than a decade of experience in genetic and genomic counseling, but then is now tending towards practicing or contributing to education for healthcare providers, for students, and for patients. So if you would like to, if you please introduce us to all these activities, we'll be happy to learn about that. Thank you.
Sure. Thank you so much. I'm happy to be here. And I'm going to kind of move through my early slides pretty quickly that are more of an overview, so I can kind of jump into the meat of the education activities that we've been working on. And we're going to specifically talk about kind of moving that needle from returning results by geneticists and genetic counselors, and the role that we as genetic providers can play in helping train and equip other types of providers to do this kind of work. So first slide, please. So a little bit of context, the larger study that what I'm going to be talking about and what that work fits into is a project called SouthSeek. This is an NIH-funded project in the US, specifically in the southeast part of the United States, and a project that is led by the folks where I'm from at Hudson Alpha, as well as folks down the road at the University of Alabama at Birmingham, namely Bruce Korf, who's in this session as well. Next slide. So the purpose of SouthSeek is to explore the use of whole genome sequencing in NICUs, so neonatal intensive care units, and it probably goes without saying that babies that are in NICUs are somewhat enriched for having genetic diagnoses, and in a lot of cases rare genetic diagnoses. And so there's a lot of interest in exploring the use of genetic testing and whole genome sequencing in that population. There's certainly challenges with that, with a lot of competing complex medical issues at hand. And when you've got small babies that are very early in their life, their phenotypes may not be super well established at that point. And so the idea is that genome sequencing and taking a very broad approach to genetic testing could be really useful in casting a wide net and getting diagnoses as efficiently as possible for these babies and their families. In the southeast of the US, as well as I think across the globe, there is certainly a lack of geneticists and genetic counselors to be able to necessarily be involved in all kinds of genetic testing that's being done. And as genetic testing gets more common, that's only going to become a bigger gap. And so in addition to getting diagnoses, one of the major aims of SouthSeek is to look at using non-genetic providers in the NICU to actually effectively communicate results and kind of keep the entire testing process within the NICU itself. Next slide. So there's a lot of data on this slide. I'm not going to go through all of it. I just wanted to give you a sense of, we've currently got a little more than 230 probands. We're about halfway through the study, so we're hoping that number goes up to 400 or 500 by the time we're done. Many of our probands and their families fit a kind of broad definition of diversity that goes beyond race and ethnicity, but also includes being from a rural area or low income levels and those kind of things, which we are very happy with that high level of that broader diversity. Our diagnostic rate is hovering around the 30% range. The babies that we're enrolling are not every baby in the NICU. Just being premature isn't going to get you enrolled in SouthSeek, but we do have a relatively loose set of criteria as far as having kind of other interesting medical issues at hand. And then over on the right, you can see that we're giving results back largely in person. We prefer to do it in person, but we also do it via phone sometimes. And our turnaround time from when a baby's enrolled to we're ready to give results back to a site is hovering a little above 2 months. We're certainly working on trying to bring that down as much as we can. Next slide. So the way that we're really testing this model of scaling this up and using non-genetic providers is we're running a non-inferiority clinical trial where our proband families are being randomized at the time in which results are ready to either get the results back by a genetic counselor at their site or through a trained non-genetic provider. Our main primary outcome for this is parent and caregiver empowerment. And so we've got some patient surveys that the parents are filling out after they get their results back to try to get at that. That data we have not analyzed yet because we're in the middle of this clinical trial. So I don't have that data to share, but I do have some other really interesting data to share as to how this is going. Next slide. So a little bit about what training looks like. As I said, we're using trained non-genetic providers. The way this has looked is myself and my team largely have traveled to each of our clinical sites. And I'll echo the sentiment of a previous presenter that while this is not super scalable, the idea of embedded hands-on training is kind of a gold standard. And so we wanted to do the best training we possibly could and get the high-level engagement from these providers who graciously have agreed to kind of jump into the deep end of returning genome results. So we spent about a half day with the providers. We did some lecturing, but in very short snippets over the course of the time. We really focused on small group discussion, hands-on activities, letting them see results, talk through them, and then we ended with a simulation activity where they actually had to give a result to one of us after doing a little bit of reading and preparing and getting some real-time feedback, which we actually thought they would all really hate. And it turns out that was their favorite part of the whole training. I think that's largely because we had taken the time and we had a good amount of rapport at that point, and they knew us and they trusted us and we had a working relationship. We did have a virtual option if people missed training or they came into the study late, but the in-person was gold standard. Next slide. So this is just some data from that. We had our providers fill out surveys before and after training. The big point here is in the graphs in the bottom where it shows how the needle moved in both the provider reported confidence in both reading results and managing care based on results. Our sample size is fairly small, but we were very happy to see that needle kind of strikingly move from not very confident to feeling pretty confident in these skills. Next slide. What we're doing in the study is myself and my team, we're audio recording all disclosures across all of our sites. And then my team is actually looking at those and listening to them and tracking errors. So major errors that we think have a strong possibility of impacting patient care, we're gonna call that provider and tell them about it. The minor errors we're gonna let go, but we're tracking them to help further develop education in the future. Next slide. And so here's the big piece of data that I wanted to show you. So at this point, 44 results have been returned in the experimental arm of the study. Most of those were negatives because most of our results are unfortunately negative, but we did have a number of positive and uncertain results. Over half of our returns by non-genetic providers did not have any errors that we identified at all. And most of the errors that we did identify were in that minor category. There were, about 10% or so of cases have had what we would consider a major error, and those have been communicated and corrected by those providers. And we have seen over time the rates of major errors have gone down as providers have learned from their kind of past errors. Next slide. So some examples of what these errors look like and how we've been calling these. In the major error category, the one that we have seen recurrently, and this is probably where I'll kind of stop my presentation after it's just describing some of these errors, is the overinterpretation of negative results, where a provider, we haven't found anything on genome sequencing and the provider says things to the participant family like, this rules out genetics, or this means it definitely was not inherited, or this definitely means this isn't going to happen again. And we as genetic providers know that that is certainly not the case, but there is this strong desire to be reassuring to these families. As well as some just misquoting of inheritance and recurrence risks. For minor errors, those are things where a provider didn't say anything that was probably going to impact patient care in a negative way, but either they left something out that we thought was really important and was on the report that they didn't talk about, like the lack of secondary findings being found, or just missed opportunities to clarify complex topics. One in particular that comes to mind is a case where a baby, we made a diagnosis and it turns out that the parent actually had the genetic change as well, but was much more mildly affected. And a provider made a statement about the parent being able to be a roadmap for helping the child not have as severe symptoms, which is not quite right, and fails to kind of expand on the idea of that people with the same condition can have very different presentations and you can't necessarily modify that. So those are the things that we're hearing, and we're We really love this part of our job because I think it's going to make us better educators going forward, being able to have some insight into what is being said and what's happening, and where the current gaps remain for kind of future development.
Okay.
So I will kind of stop there, and I'm happy if people are interested in more of the data that we have around this, I'm happy to share it offline.
Thank you. This is beautiful data, but it's, well, nice and detailed, of course. So I don't see any specific questions other whether this is translatable, but this also will be dealt with in the panel discussion. How do we reach all possible public populations with results from initiatives that have been local? So thank the 4 speakers for this nice and quick overview of very different initiatives in rare diseases and genomics. So Bruce, it's my pleasure to hand over back to you for the panel.
So what I would like to start with, there are a number of questions that have been posted in the chat, and we certainly welcome additional ones over this next few minutes. I'm going to ask one question that came up in the chat, but I'm going to actually ask it of all the panelists, and I'll paraphrase it a little bit. And that is, whether you are from a low, middle, or higher income country, one thing that we all have in common, I think, is that there are disparities of access to healthcare within all of our regions. And what I'd like to ask the panelists is, how do you address that? There are underserved populations all around the world, and how do you engage these underserved populations in the programs that you described? So I'm going to just ask each panelist, starting with Michelle, if you would please, just to briefly address that.
Yeah, it's not an easy answer. For us in New Zealand, our research is guidelined by principles where it's vital that we have the treaty principles, so it makes sure that our Indigenous population are represented in all our research, and the same in our teaching. So in our medical education program, we have a Hora Maori component to our medical education program that embeds Maori principles. And there's a number of documents we use in New Zealand that provide us cultural reference points for engaging with our Indigenous population, with Maori, for biobanking, genomic research. So that's at that level. And at the education level, schools have become much better at embedding our multiculturalness at the school level in terms of having specific programs. We have Maori immersive schools, and just trying to, as for us, we try to do outreach work with schools to normalize what we do, but in a way that is accessible to all people. It's not a solution, and I realize I probably haven't answered your question, but I don't think it's an easy problem to solve.
Thank you. Jürgen?
Yes, I'm happy to address the question, and if I may, I will actually talk about 2 countries I know a little bit about. So I will start with Australia, which of course is a developed country, and there are disparities. Some of them are socioeconomic, like everywhere else in the world. Some of them are also driven by what's called the tyranny of distance in Australia. So I live in the northern beaches of Cairns, which is about 2,000 kilometers from the capital city of my state, which is Brisbane, and probably 2,500 kilometers from the capital of Australia, which is Canberra. So the distances play a great role in Australia. And so if you live in the outback, clearly there are going to be issues with delivering healthcare. One of the positive things that has come out of COVID is that telehealth is now covered by Medicare, which is the government-funded healthcare in Australia, and it's free for everyone. So that's one of the positive things that came out of COVID. We spent quite a bit of time talking about Indigenous populations, and again, I will use the example of COVID's. The Northern Territory, which is the territory or state next to Queensland where I live, but also in Queensland, north of Cairns, is Cape York, which has lots of Indigenous people. And these populations were essentially sealed off. So travel is not permitted for people who are not from these communities to protect these individuals, indigenous individuals, from COVID. In fact, Queensland, like many other states in Australia, has sealed its borders off to the rest of Australia. And Andrew might want to chime in on that. The other country I want to spend a little bit of time on is Ecuador, where I spent some time. And before the COVID crisis, but also there was an economic crisis in Ecuador. But before that, healthcare there was very interesting for an emerging country. Doctors to visits were free. You could just walk in essentially at any time. The doctor, if I didn't have an appointment, would usually see me within 2 minutes. And pharmaceuticals, drugs, were actually stored in a cabinet in the doctor's office, and it was something that he had there, like paracetamol. He would snip off with his scissors 4 tablets of paracetamol and give them to me, also for free. Now, going back to or moving forward to COVID, I don't know how well that has been publicized around the world, but there are thousands, probably 10,000 deaths from COVID in Ecuador, which is a country of about 16 million. Thousands of them in the largest city, which is Guayaquil, and there are heartbreaking videos of people who are dying in the street, bodies that are being basically dumped in front of hospitals. So the healthcare system in Ecuador has been totally overloaded by this pandemic, and for me to watch that, I will say, is absolutely heartbreaking. I hope Ecuador, like all other emerging countries, will receive the help that they need in terms of diagnostics, and also in terms of care for vulnerable populations, and for diagnosing affected individuals and treating them. And I think I'll leave it at that. I don't know whether Andrew wants to chime in on indigenous populations in Australia, but I mentioned a few things about indigenous populations in Australia.
Very briefly, Jürgen, I think you've covered it very well. I mean, it's a big problem in Australia, and as you said, we've got hundreds of different language groups amongst our Indigenous population, and it's about negotiating with all of them. The work that we've done so far is certainly focused on the big cities around the country, but there's a big focus in the next iteration of what we're going to do is really very much focused on rural, remote and Indigenous areas, because we know that's a big area of disadvantage, and how to overcome that, as you say, with the tyranny of distance. It's challenging, but that's a big focus of the next piece of work.
Thanks. Cecilia, do you want to comment?
Sure. This is certainly a very important question for us as well. We have both socioeconomic disparities, as only 30% of our health system is private and can have access to comprehensive genomic testing, and also geographic, because we are a very narrow and long country and we're not very well connected. So some ways that we found to help with this is that we've tried to collaborate with centers all along the country with some success, particularly in the south of the country, to try to include the population from there, independent of their income. And also we hope to impact with our research in the government and develop public policies that will help get genomic testing and this diagnostic and treatment pipeline for patients with rare diseases from the government to the people, because that's a way of sort of making them equal for everyone. But we're striving for that now.
Thank you. Kelly.
Yeah, I'll just briefly make a comment about, one of the big goals of the particular project that I shared about is thinking about how do we move the practice, or at least the front lines, the practice of genomic medicine out beyond the genetics clinics and into the more kind of frontline medicine. And we know that every time you ask for a family or a patient to take another step, you're going to have drop off. Whether and that's outside of whether it would get paid for or not. That's just simply folks taking the effort to getting time out of work or school or traveling a distance to go show up to another specialist, and especially if there's some misconception or barrier that they think they don't need that or it's not relevant to them. And so when we think about our NICUs and our neonates of, you know, you've got a captive audience there where you can get the testing done that is going to be valuable in getting a diagnosis, and having that done while babies are still in the NICU and not waiting for, I know we've got a local hospital that I think their general motive is, let's get these babies discharged so they can go see genetics outpatient. And you're gonna lose babies every time that happens, because babies may pass away or they may not ever show back up in outpatient genetics. And so capturing patients while you can, and getting them the genetic access that they need, as well as moving genetics out into community hospitals and community providers so that you don't have that instant in access of who is willing to travel to large areas.
Great, thank you. One other question that's come up for individuals that I'm going to generalize for the sake of the entire panel, and maybe the last question we'll have time to do, has to do with educational activities that have been integral to your programs. And I guess the kind of basic question is if you can just briefly give us a sense of kind of what the level of investment has been in the potential for sharing some of the educational resources that you've developed in order to move your programs forward. So, Michelle?
In terms of, am I happy to share resources, or?
Yeah, I mean, what kind of educational programs have you needed to implement, and yes, are you able?
Oh yes, so for me, it's, we've developed, we're trying to develop a combined competences with our other medical school, the University of Auckland Medical School. So in New Zealand, we have key genomic competencies that we want all of our TIs, our training interns to graduate, our med students to graduate with. But we've been working on that. So it's a set of core curriculum criteria. And then part of what I'm doing is how we're delivering that for fifth-year med students. And separate to that, we're looking at how we develop the curriculum. We've developed a curriculum and a certificate for postgraduate training for non-genetic specialists who need to upskill in genomics.
Okay, Jürgen?
Yeah, so in terms of education, the ERDIC and the DSC specifically interacts actually with patients and patient advocates. And I must say that they have a great deal of interest in genetics and genomics, especially for rare diseases, which are, of course, very often genetic. So one of the things that we hope to start either later this year or early next year, and I think I mentioned that already a couple of times, is a more omics-oriented working group and task force. And hopefully one of the things that will come out of that is educational material, especially for patients and patients advocates. The other thing where education plays a great role, and I will be a little immodest by saying, because I'm the one who's leading that particular part, and that is the Indigenous Task Force. So providing culturally sensitive information and appropriately to Indigenous populations on genetics and genomics of rare diseases is, of course, a challenge. As Andrew has also mentioned before, there are hundreds of different languages that are still alive in Australia in Indigenous populations. So this is indicative how these groups are different. And so personal relationships with these groups are very important in terms of bringing information to them and then relaying that, especially through emails. So that is something that is on the drawing board also for the Indigenous Task Force. I don't know, again, if Andrew wants to contribute to that.
No, but I don't know, Bruce, I mentioned sort of the education things that we've got in play. Around the country, each state has something like Australian Genomics, but on a smaller scale, and each one of them has involved all the genetic specialists in the country, whether they be genetic counsellors and clinical geneticists. but also the non-specialists. So I think that's really important to get cardiologists, oncologists, and everyone else involved and engaged with this with hands-on projects. That's been most effective. We've also set up courses now. We have some rapid master's level courses for people to dip into, whether they be either undergraduate level or also for the medical specialists as well. So that's been very successful. But lots of engagement with the public as well, as wide as possible, not just Indigenous, but also people within the various cities, but also in rural communities as well. There's been outreach activities which have also been successful and taken up widely by a lot in the population.
Thank you. Cecilia?
So there's only one training program in genetics in Chile, and there's no programs in for genetic counseling. So what we've done is trying to engage students early on in the process. So having medical students rotate with us and giving them classes, and not only to medical students, but also to other health professions. Just providing education early on. We've made sure to have courses for both medical and non-medical professionals to sort of disseminate the word and bring interest in these topics among the public. And one very successful, I think, thing we've done in terms of education is engaging patient groups into these conferences, because they're major drivers. They're major drivers for public policies, for disseminating knowledge about rare diseases, and for putting pressure on getting things done. So
thank you. Kelly?
Sure. So we certainly have developed the training program for these non-genetic providers in South Seek. And so I'll kind of focus comments on that. We do a lot more in education than that, certainly. And our target audience for what we developed was we had mostly physicians, but we had a handful of nurse practitioners and PAs that we trained as well. We are certainly open to sharing what we have built so far. I know that I can say myself and my team, we're also really looking forward to doing a lot more synthesis with the recording data and the errors and the gaps and misconceptions that we still see remain, and as kind of a hopeful future direction of taking that feedback in and doing some kind of retooling and modifications to the training, which we think worked really well, but certainly can always improve, and developing a kind of modified, improved course, and ideally putting that somewhere in an online platform that could be much more broadly disseminated. You know, one of the things we've really tried to do is, and I think a previous speaker mentioned this, that focusing on actions and skills. The goal is not to teach genetics 101 to these providers, but really focus on the actions that we want them to take, and helping them and supporting them in those actions, and giving them what they need to practice genomic medicine, versus necessarily understanding all the background, although that kind of stealthily comes in along the way.
Okay, well, thank you. I think we are going to need to end the discussion at this point, because otherwise we are really eroding into the break. So with this, let me thank all of the speakers and panelists and Garrett in this session. I think it was a terrific session.